So our criteria for Alzheimer's disease were published in 1984 in a work group led by Guy McCann. And in those criteria, it was clear that Alzheimer's disease equaled dementia of the Alzheimer type. So the sequence was determine if this patient has dementia, and then determine which dementia they have, and if it looks like Alzheimer's disease, you exclude the other things. That's what Alzheimer's disease is. So it was inherent in the definition that Alzheimer's disease was a dementia. Moreover, we called it probable Alzheimer's disease because we couldn't be certain until the patient came to autopsy. Certain Alzheimer's disease was diagnosed when the patient came to autopsy. So this was somewhat daunting to patients, right? We'll know later what you have. So that was our situation from 1984 until 2007. And since then, we have learned that Alzheimer's disease, as Charlie said, occurs on a spectrum of severity. So the processes begin to change in the brain and there are no symptoms. And then gradually symptoms develop, but the patient does not meet criteria for dementia. And then gradually the patient worsens and now they meet criteria for dementia. So dementia is the end of the disease. It's not the disease. It's just the end part of the disease. So it's preceded by more mild symptoms, and that's the basic new concept. I'm going to try to expand on that. So what we see, and this is something like the graph that Charlie showed you, there's increasing cognitive impairment over time. It's undetectable in the early phases, that is, they still perform normally even though they be declining from their own baseline. There's increasing nerve cell dysfunction over this period, and so they're moving from no symptoms to dementia, with now dementia being the end of the illness. So the reason that we have come to understand this is because of the rapid evolution of biomarkers. And Dr. Shelton is going to tell us much more about these, and you'll hear about biomarkers all day. Because in the first part of the disease, there are no symptoms. So the patient cannot be diagnosed clinically, but they already have positive biomarkers. There's already amyloid in the brain. So that's the first phase of the illness. Second phase, mild symptoms. We've called that mild cognitive impairment. Patient usually has memory abnormalities. They're having trouble recalling things, but they're still driving. They're still beating you at bridge. They're still, they're still gaming. They're still doing all of the things that we expect a normal life to include. And of course, their biomarkers continue to be abnormal. As that progresses then, they cross that line to having impaired function. And the difference between mild disease and dementia is impaired function. So that's where we make the diagnosis of dementia, and we've traversed this pathway from no symptoms to dementia. So the new criteria then depend on amyloid biomarkers or neurodegeneration biomarkers. So the amyloid biomarkers would be amyloid imaging. You're going to see a lot of those, and as Charlie said, that's just been approved by the FDA. It'll be present here in the city within the next few weeks. Or decreased amyloid, specifically the length of amyloid that we're worried about is 42 amino acids long, so we call it A beta 42 in the spinal fluid. So what happens is the amyloid is progressively deposited in the brain, and so it goes down in the CSF. It's no longer present in the CSF. So you can measure either the reduction in the CSF or the accumulation in the brain because they are the reciprocal processes. The other class of biomarkers are neurodegeneration biomarkers, and these would include atrophy on the MRI, hypometabolism, as Charlie showed you on FDG PET, hypoperfusion, that is reduced blood flow on a SPECT scan, or increased tau or phospho-tau in the spinal fluid. All of those are neurodegeneration or indicators of neuronal injury. So as we think about this progression from abnormal biomarkers, but no cognitive symptoms. And next is, and by the way, the first abnormality are amyloid abnormalities. Then as MCI evolves or prodromal disease occurs, there are amyloid and neurodegeneration biomarkers, and then that's followed by the dementia syndrome. So one would see a positive amyloid imaging, then positive amyloid imaging plus atrophy on the MR. I think you can see I don't have a pointer here, I'm sorry to say, but you can see that the temporal horn is enlarged, and then finally they develop the full dementia syndrome with cognitive impairment and functional impairment. So this is the spectrum of evolution, and you see that the first changes you can see are the changes in the amyloid. Now, there are two groups who have worked on trying to figure out what we should call these different phases. And Dr. Sheltons and I are both members of the IWG, the international work group led by Bruno Dubois. And then the other work group is from the National Institute on Aging and the Alzheimer's Association. I'm going to call attention to the many similarities between these two approaches. So both of them identify a cognitively normal, biomarker positive group. We call that group at risk with Alzheimer pathology. And the NIA group calls it preclinical Alzheimer's disease, but the syndrome is the same. Next, we go on to mild symptoms like MCI, which we prefer to call prodromal Alzheimer's disease because it is the first phase of the symptomatic form of Alzheimer's disease. The NIA tends to use the term MCI due to AD. Then there's the final phase on which there's great agreement, which is Alzheimer's disease dementia, again seen as the final phase in both of these sets of criteria. Patient has the clinical phenotype, the clinical syndrome of Alzheimer's disease, and positive biomarkers. So you'll see the evolution of both of these sets of criteria. There are two work groups that are trying to understand how to integrate biomarkers into our clinical approach. Now, what are some of the implications of this? I'm interested in implications. Well, it means that the number of people with AD is much larger than the number of people with AD dementia. So you've heard all of these terrible figures, right? That there are 5 million people in the United States with Alzheimer's disease. In reality, those figures relate to dementia. So there are 5 million people in the United States with Alzheimer's dementia, but there are 10 million people in the United States with Alzheimer's disease, if you include that pre-dementia form of the illness, because one spends about as much time in the pre-dementia as you do in the dementia phase of the illness. So all of our estimates are about twofold too small for the actual existence of this disease. So if we project forward to 2050 and we say there's going to be 100 million victims of Alzheimer's disease by 2050, those are the dementia victims. There are 100 million, but there are 200 million people in the world with Alzheimer's disease by 2050 if we don't find therapy. So all of our estimates are too small. We also know that with early diagnosis, people will live for many years, right? And now a person is diagnosed with Alzheimer's disease when they have dementia. They're already pretty cognitively impaired. So they're not really reflective often at that phase. Now we could tell people with a biomarker that they have Alzheimer's disease, and we could tell them at a time when they have very few symptoms. We could tell them if they're at high risk for Alzheimer's disease when they have no symptoms, because they already have a positive biomarker. So what will this do to people? How will we think about it? Well, we'll need to think about how to live with Alzheimer's disease, because people will have the diagnosis for 20 or 30 years. So it's not just a dementing disorder. It is a whole life. It might be a third of your life that you spend with the diagnosis of Alzheimer's disease, let's say 60 to 90. So it raises many conundra, like diagnosis without available therapy. Would we want to do that? If you can't offer somebody something, would you want to make a diagnosis? I'm not Solomonesque enough to know the answer to that, but it's a question that we'll have to answer as we move forward with these biomarkers. So a few thoughts about therapy. All of our available medical therapies are approved for AD dementia. That's who was included in the trials. So we do not have any available therapies that have been approved by the FDA for prodromal AD or for MCI. As a matter of fact, all of the use of our medications like cholinesterase inhibitors and memantine would be off-label, and they might not be reimbursed, right? The payers want a close relationship between the approved label and the drugs they pay for. And all of this period of the disease that we can now see with the biomarkers would be off-label unless we do new clinical trials to show that the drugs are effective in that period. So you can see that the identification of this phase of the disease is dependent on biomarkers. And there's lots of problems with biomarkers. They're expensive. We expect amyloid imaging to cost $4,500 if you pay when you get it, and $5,500 if you pay it over a period of time. That's a lot of money. I don't think a lot of people will get it. Not widely available. It'll be available in the urban centers, but it will not be available to rural patients by and large. It may be misinterpreted, right? If you look at the sensitivity and specificity of the published figures for those scans, there are false negatives and there are false positives. We, by the way, show you these brilliantly colored pictures that no one could mistake for normal. That's not actually what the radiologist sees, right? The radiologist sees this kind of gray image that's a little different from normal and is much more difficult to decide what's negative and what's positive. So there may be both false negatives and false positives. And they require expertise, and they have been training technicians to be able to read these scans effectively, but you should know that there are limitations in the reading. So MR is the most commonly available biomarker. Where the green arrow is on the left, you see a normal, robust, healthy-looking hippocampus. And on the right, where the green arrow is, you see a shrunken hippocampus characteristic of Alzheimer's disease. This is the imaging that we get here at the Cleveland Clinic Center, and we get a quantitative readout, as Charlie mentioned. So in an extreme case, as this is, the distinctions are easy. In more subtle cases, of course, they're more challenging. Here is the dramatic example of amyloid imaging with the normal image on the left, where there's no amyloid deposition in a normal elderly individual. And in Alzheimer's disease, there is very substantial deposition of amyloid. And this is the kind of signal that one sees before the onset of symptoms, in the MCI phase of the disease, and in the dementia phase of the disease. So I'm showing you Alzheimer's disease on the left, and I'm showing you a healthy control above on the right. And I define you to see a difference between those two scans. They're just the same because the amyloid deposition is equally severe in the amyloid positive healthy controls as it is in Alzheimer's disease or Alzheimer's dementia. This is what we knew from the pathology of the disease, that people were laying down amyloid, and they were doing so about 10 years before the onset of symptoms. This was defined pathologically. This was always a mystery to us as to why we were seeing patients who came to autopsy and met criteria for Alzheimer's disease and were asymptomatic. Now we see the exact same phenomenon with amyloid imaging. The imaging changes roughly 10 years before the disease becomes symptomatic. So these abnormalities are highly predictive of the development of the dementia state. So I'm showing you this dramatic graph from Kai Blenau's lab. The light blue at the top were people who had normal spinal fluid, but they had mild cognitive impairment. So they had memory impairment that looked like Alzheimer's disease, but their spinal fluid was normal. And you see that over 60 months, 5 years, almost nothing happens to that group. On the other hand, in this group here in purple, this group had the same kind of memory impairment, but they had low A beta and high tau in the spinal fluid. So they already had the Alzheimer type changes in the spinal fluid. And you can see that by 60 months, 80% have now developed Alzheimer's dementia. So that you can see that the predictive value of the abnormalities in the spinal fluid is very high. And if they already look like Alzheimer's disease, it's likely that that person, of course, already has Alzheimer's disease. And they're going to progress rapidly to Alzheimer's type of dementia. Now, I'll just point out one important thing about prognosis. Because when you're talking with an individual patient, yes, they're interested in what generally happens, but they're also interested in what is going to happen to me, doctor. What does my spinal fluid or my amyloid imaging mean for me personally? And I think you have to be somewhat reserved in that advice, because you can see that although 80% of patients change from MCI to Alzheimer's dementia in 60 months, 20% didn't. So they went 5 years, and they still just had MCI, right? Every patient hopes they're in that 20%, and we have to give them that hope. And we can't take it away from them, and we don't want to, because we don't know who comprises that 20%. So it's very important to know and to think that although the biomarkers are extremely positive in terms of their predictive value, there's still a lot of things we don't know. And we don't want to overstate the case to the patient. We want to give them hope. We want to use them to inform our decisions, but we also want to know their limitations. So here's just an example of the predictive value of amyloid imaging. When the MCI patient has a scan that looks normal, and there's a little signal there, but it's in the white matter, they will have the same trajectory as healthy controls. They will not convert to dementia of the Alzheimer type. On the other hand, when the MCI patient has a scan that looks like Alzheimer's disease, the likelihood of their progressing to Alzheimer's dementia is very high. So this scan, of course, is already the scan of Alzheimer's disease, and it goes on to the scan of Alzheimer's dementia. So why does my particular group and the group that Phil is with, why do we not like the concept of MCI and prefer prodromal? And I'm not sure that this is an earth-shaking difference, by the way. But the two criteria do diverge on this aspect, and we do so because MCI is nonspecific and heterogeneous. It's very important for you to realize that half of the MCI patients you see do not have Alzheimer's disease, okay? Half of them do. And we prefer to speak specifically to the half that do and call them prodromal Alzheimer's disease. And we don't know what to call the other half. Whereas the more embracing concept is MCI, and that would include half of patients who have AD and half do not. So some progress on to Alzheimer's dementia, some remain as MCI, some revert to normal cognition, that is some MCI patients, and some progress to non-Alzheimer type of dementias. We like the concept prodromal AD because we're interested in the early form of AD, and MCI is not necessarily the early form of AD. Here's a follow-up study in which patients developed a dementia syndrome. So this is not all the ones who stayed MCI or all the ones who got better. This is just the people who died of a neurological disease having presented with MCI. And even with that group, 30% of them turned out not to have Alzheimer's disease. So MCI is a heterogeneous diagnosis. You should not use it to equate with Alzheimer's disease. Half of them have the disease, half of them do not have the disease, and we need to be cautious in the application of that information. So Alzheimer's dementia, just to speak about this for a moment, 1984, probable AD, they met the clinical criteria. Possible AD, they had a single progressive deficit. We'd now call that MCI or prodromal AD. And definite AD was autopsy-proven disease. Now, currently, we would use probable AD if they meet the clinical criteria, but we would use AD dementia if they have clinical criteria and a biomarker. So we would do away with the word probable because we feel confident in the diagnosis if the biomarker is positive. Some practical implications. This says FDA will approve this soon. It actually approved it about 4 weeks ago after I made these slides. So amyloid imaging is coming. It can be done in any hospital with a PET scan, so anywhere where people are getting cancer scans, for example, they can do this scan readily available. Charlie made this point that lumbar puncture and CSF analysis is less expensive and more widely available, though it's not covered by Medicare. It is less convenient. Very few of my patients come in and say, Dr. Cummings, I'd really like a lumbar puncture today. But Phil will tell us about this. Phil's patients come in and ask him for a lumbar puncture. So we're going to learn how the Europeans do that. But it does provide powerful evidence of both the amyloid by going down and the neurodegeneration process with the tau going up. So looking ahead for a moment, I'm impressed by how few good biomarkers we have. You know, we've got amyloid PET, FDG PET, MRI, CSF A beta, CSF tau. We've got 5 biomarkers. There are thousands of processes in the cells, and each of them could have a marker of the intracellular change that might be valuable in terms of diagnosis, prognosis, or disease tracking. So I think we will look ahead to blood-based evidence of Alzheimer's disease. I think we'll look for evidence of expanded brain imaging. I think we'll have tau imaging. I think we'll have a Lewy body or alpha-synuclein imaging. I think we'll have TDP-43 markers, which is another protein that accumulates in frontotemporal dementia, and an expanded set of CSF biomarkers. So I think this little list of 5 that we have now will look back as the primitive beginning of the biomarker understanding of Alzheimer's disease. So this is the last slide just to wind this up. In 1984, Alzheimer's disease equaled dementia. We have now radically reformed this concept. Now AD is a spectrum of severity. We only use the term Alzheimer's disease for somebody who has symptoms, so that would include prodromal and Alzheimer's dementia, and then we use Alzheimer's disease risk for someone who has a positive biomarker and no symptoms. So there are preclinical, prodromal, and dementia forms. We can only diagnose the early forms by the use of biomarkers, and there's just been astounding progress in the use of biomarkers. Amyloid imaging will be available in the next month or so here in Las Vegas and anywhere where there's a PET scanner, and they have a trained technician, and the technician, by the way, can go online and do the training. It's available now. And I think that early diagnosis will begin to reshape the field as we're able to reach back into earlier and earlier phases of the disease. But it raises a lot of questions, which I mentioned. How will people live with a diagnosis for a long time? Should we provide a diagnosis when we don't have therapy?